So again, thanks for inviting me to speak to you about breast cancer basics and surveillance. I get the feel after hearing Pat's introduction that most of you already know quite a lot, but I'm going to include some basics just in case there are any neophytes on the lecture. And in this talk, I'm going to talk about breast cancer detection. And when I'm referring to women who have not had breast cancer, I'm going to talk about it as screening. And when we're looking for cancer in women who have had breast cancer, I'll call it surveillance. So here are my disclosures. I'm here, as you heard, on a volunteer basis, and I have no relevant financial conflicts. Today, I'm going to explain the importance of early detection of breast cancer and the optimal strategy for achieving that in as many women as possible, whether it's a first cancer or a recurrence. I'm going to describe the flawed process used in making guidelines that affect millions of Canadian women, and I'll discuss the evidence for screening mammography starting at age 40. We know that mammograms save lives, but they're not a perfect test. I'll continue with the evidence for supplemental screening for women with dense breasts, the various tests that can be used, and the recommended surveillance for women with breast cancer. Now, most women are aware that the risk of getting breast cancer is higher in women with a family history, especially in a first-degree relative. But women and even sometimes physicians are surprised when they learn that 85% of breast cancers occur in women with no family history. And that's why all women need to be screened, not just those at increased risk. The most significant risk factors for breast cancer are, number one, being a woman, and number two, growing older. And there are many other factors that can increase a woman's risk of getting breast cancer above average. Now, some are beyond our control, like those listed on the left, like having one of the breast cancer genes, having had chest radiation for lymphoma, having dense breast tissue, family history, as I mentioned, having had a previous biopsy that showed atypical cells, women who start their periods younger than average or go through menopause older than average, or women who've had no children are also at increased risk. And of course, women who've had breast cancer are at risk of it recurring and at an increased risk of developing a second breast cancer. The list on the right is a list of factors that can be controlled to reduce risk, which is important to all women, including survivors. Minimal combined hormone therapy after menopause, minimal or no alcohol, a low-fat diet, moderate exercise, not smoking, and maintaining a healthy body weight can all reduce risk. So most of you know what the signs of breast cancer are. It can show up as a lump, of course, but not always. And it's important to remember that most lumps are not cancer. Cancer can show up a number of ways listed here. This photo is from a website called Know Your Lemons that shows the many ways breast cancer can manifest. They also have an app, and you should check it out. Now, I'm going to be including a number of links during the talk. Don't feel that you have to write it down because we are hopefully recording this, and you'll get the recording later. Many of the goals of screening apply to surveillance. We do screening to find cancer earlier, sometimes years before it can be felt as a lump or seen as dimpling and so on. By screening, we can find and treat cancer earlier and save more lives. And when a recurrent or new cancer is found early, it can be successfully treated with less aggressive treatment than would be needed if it's detected when it's more advanced. Early detection is our goal because 5-year survival drops as the stage at diagnosis is more advanced. This chart applies to the detection of a first cancer. The overall 5-year survival is 87%. But when a woman's diagnosed at stage 0 or 1, before it has started to spread beyond the breast, it's virtually 100%. And happily, about 65% of women are diagnosed at these stages. Cancer only becomes life-threatening when it is not confined to the breast. 5-year survival is only 22% when cancer is diagnosed at stage 4, and about 6% of women are diagnosed at that stage. Here's some examples showing common object sizes. Mammograms can find cancers less than 1 centimeter, which is the size of a pea. A peanut is 2 centimeters, and stage 1 cancers can be up to 2 centimeters in size. When a cancer is 2 to 5 centimeters, we call it stage 2. A Lyme is about 5 centimeters, and when a cancer is that big, it's stage 3. And any size tumor that breaks through the skin or gets attached to the chest wall is stage 4. There are different ways to screen for cancer. Breast self-exams are currently discouraged by a panel called the Canadian Task Force on Preventive Healthcare. They make breast screening guidelines for average risk Canadian women aged 40 to 74, and I'll explain later why this recommendation is wrong. Mammography is the gold standard, and I'll describe some other tests that can be used in special situations and some newer ones that are emerging. Please know that thermography has been thoroughly discredited. It measures skin temperature so it can find big cancers close to the skin, but those aren't a problem for us. Thermography misses smaller cancers deeper in the breast, and it has loads of false alarms. We know that annual mammograms starting at age 40 save the most lives. But the Canadian Task Force says that women in their 40s should not be screened, and that panel influences screening policy across Canada. The mortality rate for breast cancer in Canada was unchanged from 1969 to 1996, but from 1989, after screening started in Canada, this dashed green line shows that the breast cancer deaths have plummeted, and this is compelling evidence that screening works. It's estimated that there have been 32,000 fewer breast cancer deaths since 1986, which is a huge indication of the success of screening and improved treatment. This observational study was done in Canada, and they obtained data from almost 3 million women attending screening programs in Canada, and they compared them to women who didn't have mammograms. They showed that overall, women who have screening mammograms are 40% less likely to die of breast cancer than those who don't, and women in their 40s are 44% less likely to die. So it makes sense to start screening at age 40. And unfortunately, only 4 provinces in Canada allow women to self-refer without a doctor's requisition at age 40. The rest don't start till 50. But that doesn't mean women can't have mammograms in their 40s, and I'll talk more about that later. There are other significant benefits of early detection in addition to fewer deaths. When cancer is not found early, women are more likely to need a mastectomy. But when cancers are found early, women can have a lumpectomy and be successfully treated. Lymphedema is a swelling in the arm and hand from blockage of the lymphatic vessels in the armpit. It's a common side effect of the traditional armpit surgery called axillary dissection done for lymph node staging, and it's usually permanent. When cancer is detected early, women can have a much less invasive sentinel node biopsy instead that has a much lower risk of lymphedema. Women deserve the opportunity to avoid this complication. It would be best if we could prevent lymphedema. The risk of lymphedema after the axillary dissection sampling is up to 33%. After sentinel node biopsy, the risk is as low as 2%. Now, many women can avoid chemo if their cancer is small and if there are no positive nodes, and they're shown to be at low risk for recurrence. This is the 4th important benefit of early detection. So we should screen all average risk women annually starting at 40. And starting at 40 is especially important for Black, Asian, and Hispanic women. They have earlier onset and peak of breast cancer incidence, which is in the late 40s, compared with Caucasian women, where the peak is in the late 50s to early 60s. As I explained, breast cancer is less common in younger women, but it tends to be more aggressive, so it's not trivial. In 2016, there were 3,300 women aged 40 to 49 with breast cancer in Canada, but breast cancer is increasing in younger women, and in 2022, they were projecting that there would be almost 4,500 breast cancers in women in the 40s in Canada. And younger women have the more potential years of life to lose. In fact, 27% of the years of life lost to breast cancer are to women who were diagnosed in their 40s. Women in the 40s nowadays are caring for young children and aging parents. They're working and contributing to the economy. They're not expendable. Women 40 to 49 may self-refer for mammography screening starting at 40 in PEI and 3 other jurisdictions. So please encourage the women in your life to take advantage. Each province and territory decides what to offer, so a woman's access to early detection depends where she lives. The left column on this chart shows that PEI is one of only 4 jurisdictions where women can self-refer starting at 40. If you don't live in PEI and you want to know what's available in your province rather than struggling to read the whole chart, I'm going to give you a website. You can look it up later. Now, some of those who oppose screening women in their 40s claim that the potential risks of screening outweigh the benefits. Well, I've just told you about what the benefits are: saving lives and the ability to have less aggressive therapy. So what could those risks possibly be? Well, the one they're most concerned about is the anxiety women experience if they're recalled from screening for more tests. And they even make it sound worse than it is by calling them false positives. They should call them false alarms or recalls. False alarms happen with all screening tests like pap smears. For every 1,000 women who have a screening mammogram, about 7% or 70 are recalled for additional tests. And those recalls certainly do cause anxiety, but it's short-lived, and it has been shown to be reduced if women are informed ahead of time that they can happen. And a false alarm is most likely to happen after a woman's first mammogram. And 95% of those recalled women don't have cancer. The majority of them will need only one or more additional mammographic pictures. Some will need an ultrasound. 11 of the 70 women will probably be told that they need a needle biopsy. Now, those are done with generous local anesthetic, and they should not be more painful than a blood test from the arm. And ultimately, of those 11 women who have a needle biopsy, 4 of them will be diagnosed with breast cancer. This chart is from the Canadian Partnership Against Cancer. You can see the false alarm rates for women in each of the decades from the 40s to the 70s. And what you can see are the recall is always higher on the first mammogram, and it's similar throughout the decade. So there's no reason to make women wait till age 50 to start having regular mammograms. In fact, the cutoff of age 50 has no scientific basis as a threshold for screening. Even though only about 5 or 6% of the women who are recalled are diagnosed with breast cancer, opponents think that we should spare women those anxiety of false alarms. And that's why they recommend starting later and screening less often, even though they know that more women will die. Women disagree. Researchers in Pittsburgh surveyed women attending for routine screening and found that 97% of them would rather have screening, even if it meant having a false alarm. And 82% said they'd be willing to have the needle biopsy if it might increase the chance of detecting a cancer earlier. The Canadian Task Force is the main opponent to screening younger women. In this comic, a member of the task force is at the grave and says, yes, regular mammograms and early detection would have saved your life, but aren't you glad we spared you all that anxiety? The task force thinks it's more important to save some women transient anxiety from being recalled than preventing unnecessary deaths. In my day-to-day practice, the women who are the most stressed are those who find out that they have a big cancer, that it may have spread to the lymph nodes, and that perhaps it could have been found earlier. They're not only anxious, they're justifiably angry. Overdiagnosis, and that's in quotations, is another concern for the task force. Now, this is a bit tough to explain because it's theoretical. It's the theoretical possibility that a woman will die of something else before that cancer might have killed her. So, for example, let's say we find a cancer and the woman gets treated for it, and 6 months later, she dies in a car accident or has a stroke, or she gets a different cancer and dies of it before her breast cancer might have been found if she hadn't had screening. The likelihood of overdiagnosis in younger women is almost zero because they're less likely to have other cancers and various diseases. The task force thinks that around half of cancers are overdiagnosed, but that's because they base their estimate on a flawed trial that was done in Canada in the 1980s. Most experts nowadays agree that the overdiagnosis is most likely in the range of 1 to 10% and probably in the lower end of that range. Here's a study where they surveyed almost 3,000 women about overdiagnosis, and 95% said they would still want to have screening. So the evidence supports starting screening at 40 and ideally annually, but when should screening stop? The task force says 74, but that's because of that old research that only included women up to age 74, and some provinces have defaulted to that. But breast cancer risk keeps increasing as a woman gets older. And if she doesn't die of something else, her risk of breast cancer keeps climbing. If a woman's in good health with a life expectancy of 10 years and is well enough to have treatment if a cancer is found, then it's worth continuing screening to find those cancers when they're small and more easily treated. This life expectancy chart is from Statistics Canada. The average life expectancy for a healthy woman at age 75 is 13 years, and at age 80, it's 10 years. The American Cancer Society recommends that women keep having mammograms as long as their life expectancy is 10 years. So stopping at 80 would be reasonable, but it depends on a woman's general health and her personal values. In the absence of other serious illness, screening benefits significantly outweigh the risk of overdiagnosis until age 90. So they should be offered screening, and that includes women who've had breast cancer. So back to this chart, the column on the far right shows the 7 jurisdictions that allow women to self-refer after 75. PEI is not one of them. In PEI, women over 74 have to ask their doctor for a requisition. And you all know that we have a big problem in Canada with not enough family doctors. So women who don't have a family doctor are going to have a hard time getting a requisition to have screening. Now, mammograms aren't perfect. And one reason is the false alarms, but the other is that not all cancers are visible on mammograms. Dense tissue is the main reason that cancers can be missed on a mammogram. Here's an obvious cancer on a screening mammogram. And the reason I'm 100% sure that it's cancer is you can see the irregular jaggedy edges, and there's some fine white dots here that are malignant calcifications. Now, not all cancers are this obvious though, and this one's easy to see because the cancer's white and the rest of her breast is dark gray. So it jumps out at you like a star in the sky, a dark sky anyway. Remember this cancer for the next few slides. Radiologists divide breast density into 4 categories, A through D. And here are the words we use to describe those categories. Category C and D are regarded as dense. A and B are non-dense. And the denser the breast, the more likely that a cancer will be missed, because it's like trying to see a snowball in a snowstorm. You can't see the white cancer when the background is white. This woman's breasts are category A, almost entirely fat, and fat is dark gray on a mammogram. If she had that cancer from a few slides ago, we'd have no trouble seeing it in her fatty breasts. These breasts are also normal, but they're not all dark gray. She's got a little more white stuff, and they're category B, and that white stuff is normal breast tissue. We'd have a pretty good chance of seeing that cancer in her breasts if she had cancer. Now, these breasts are normal too, but they're category C, and they have a lot more normal, dense tissue. It becomes harder to see cancers which are white in a background of white. We might see a cancer in her if it happened in this location, but we would miss it if it was hiding down here behind the nipple. And some women are category D with virtually no fat, and even a large cancer could be missed in this kind of breast tissue. In fact, mammograms miss up to 50% of cancers in women with the densest breast, category D. So look at the breast on the far left. This animation shows how a small cancer, easily visible when it's outlined by fat, gets harder and harder to see. And when cancer is missed on a mammogram and it isn't discovered and treated, it continues to grow and potentially spread until it's big enough to feel. When a cancer is found, usually as a lump, and the woman's last screening mammogram was negative, it's called an interval cancer because it developed in the interval between screening mammograms. Interval cancers are larger at diagnosis and more often node positive than screen-detected cancers. They tend to be higher nuclear grade and more aggressive, and they have a poorer prognosis compared to screen-detected cancers. So an important goal of screening is to find cancers on the screening and reduce the incidence of interval cancers. So how do you know if you've got dense breasts? You can only know on a mammogram. You can't tell by the size or the texture of your breasts. Having lumpy breasts is not the same as dense breasts. Lumpy breasts can even be fatty. Soft breasts might be dense. Both fatty and dense breasts can feel soft, firm, or lumpy. So the biggest risk of dense breasts is the masking of cancers. But here's the perfect storm. We have known since the 1970s that breast density is an independent risk factor for developing cancer. Women with the densest breasts, category D, are 4 to 6 times more likely to get breast cancer than women in category A with fatty breasts. Having dense breasts is the most prevalent risk factor, more so than having a significant family history. The denser the breast, the higher the risk of getting breast cancer. Dense tissue also increases the risk of an interval cancer. And as I mentioned before, they have a poorer prognosis compared to screen-detected cancers. We've known since the 1990s that women with the densest breasts are 13 to 18 times more likely to get an interval cancer than women with fatty breasts, and they have worse outcomes. We can find many of those cancers when they're small with supplemental screening and prevent them from becoming interval cancers. This study from the Netherlands confirmed that women with dense tissue don't benefit as much from mammograms. Women with dense breasts who have mammograms do reduce their risk of dying, but by only 13%, compared to women with non-dense tissue, where they reduce their risk by 41%. So you can say that women with dense breasts are discriminated against if they only have access to mammograms for breast cancer screening. Dense breasts are normal and common. About 43% of women over the age of 40 have dense breasts. Most are category C. Some women's breasts may become less dense and more fatty with age, generally around menopause, but not all. Women whose breast density does not decrease with age are more likely to get breast cancer. And while it's normal to have dense breasts, women need to know if they have dense breasts so they can understand the implications. So breast density is an important piece of health information, but women were not being told. When Dense Breast Canada began advocating in 2017, no jurisdiction was directly informing all women of their breast density in their results letter after a screening mammogram. Now, 6 Canadian jurisdictions inform women of their breast density. This fall, Yukon will start and Saskatchewan will start next year. Back to this chart. The third column from the left shows the 6 jurisdictions directly informing all women of their breast density, and happily, PEI is one of them. 6 jurisdictions let women in category D have annual mammograms. Now, ideally, all women should, and a recent Canadian study showed that provinces that screen category D women annually have fewer interval cancers, and happily, PEI is one of them. So, who needs additional screening? Well, women at higher than average risk, regardless of their breast density, need additional screening, and women at a higher risk of interval cancer, those with dense breasts, and some survivors. For women who've had breast cancer, mammography is still the first line of screening, and we know the sensitivity of a mammogram is lower after a woman's had cancer, largely because of scar tissue can make it more difficult to see cancers. Sensitivity is about 65% overall in survivors compared to 77% overall in women who haven't had cancer, and it's even lower in survivors who have category D dense breasts, about 55% sensitive. Even if a woman's first cancer was not seen on her mammogram, mammography has been shown to be effective in detecting early stage second cancers in breast cancer survivors, most of which are DCIS or stage 1 invasive, and survival's better when recurrences are detected on a mammogram rather than as a lump. Breast cancer survivors have a 7 times higher risk of a second cancer in the same or opposite breast than women who haven't had cancer. The risk of recurrence is highest in the first 5 years after treatment. Oh, sorry, that wasn't supposed to advance by itself. And it peaks in the second year. And because mammograms are less sensitive in survivors compared to overall screening population, they also have 4 times higher an interval cancer rate. All international guidelines recommend annual mammograms for survivors. Other than mammography, there's variability in the guidelines. The most recommended supplemental surveillance tests are breast MRI and whole breast ultrasound, with MRI being preferred. I'll talk about those and some other emerging tests. Here's a recurrent cancer on a surveillance mammogram as a mass. When she came for her ultrasound, we saw a mass at the previous lumpectomy site, but we also saw a second mass next to the scar where her lymph node sampling had been done. Here's another case of a recurrent cancer found on a mammogram. You can see them much better on these magnification views, these calcifications. Now, calcifications can be benign, like in scar tissue, but these were suspicious because they were fine and linear, and some of them are branching, and these were DCIS. This 50-year-old woman had a previous right breast cancer, and this mass you see is in the left breast. You can just barely see a little bit architectural distortion, and those clips are from her axillary dissection surgery. The yellow arrow is pointing to the surgical clips in her armpit, and the green arrows are pointing to the scar on the skin of her right breast. But there's something else that's much more obvious, of course. It's the big cancer in her left breast. Now, sadly, she hadn't kept up with annual mammograms, and her most recent previous mammogram before this one was 3.5 years prior. So ladies, please go every year for your mammograms. The yellow arrows here are pointing to that prior mammogram from 3.5 years ago, and you can see there was absolutely nothing there. So this cancer grew in the 3.5 years between her mammograms. The next test I'll talk about is ultrasound. Now, we published this paper over 25 years ago, and it was followed by work from multiple other institutions and then multi-center trials. And this was the first to show that high-resolution ultrasound can find cancers that are too small to feel, and they're missed on mammograms because of dense breast tissue. This international study found 5.3 cancers per 1,000 women screened in the first year, and an average of 4.3 cancers per 1,000 women over 3 years. Now, mammograms find about 5 cancers per 1,000. So these additional 5 cancers were the ones missed on the mammograms. So by doing ultrasound in these women, we doubled the cancer detection rate. And the good news is that most of the cancers were small. The median size was 10 millimeters. They were invasive, and 96% of the ones that were staged were node negative. The participants in this trial were offered a free MRI at the end of the study, and it found an additional 14.7 cancers per 1,000. So those were cancers not only missed on their mammograms, but on their ultrasounds. But interestingly, 42% of the women who were offered that MRI declined it. Ultrasound can be done with a handheld probe, or with a large footprint probe like this that automatically scans about 1/3 of the breast, and it's called ABIS, or automated breast ultrasound. ABIS is available at some clinics in Ontario and Alberta, but I don't think anybody's doing it in many of the other provinces. Any ordinary ultrasound machine can do breast ultrasound, but not all clinics offer it. And because of the task force guidelines and some of the wording on provincial websites, some family doctors refuse to refer their patients for a screening ultrasound. In BC, we've been able to do supplemental ultrasound since January 2019, thanks to advocacy by the volunteers from Dense Breast Canada. The supplemental screening ultrasound is now covered by provincial health insurance for any woman in category C or D, but she needs a doctor's requisition. My colleagues published our outcomes in the first year after it was covered, and we're finding 7 cancers per 1,000. The average patient age was 55, and they're all small and node negative. And remember, these were cancers that were missed on their mammograms. Now, importantly, 40% of the women had no family history, and 60% were in category C. So all women in category C and D density deserve supplemental screening, even if they don't have a family history. So to summarize breast ultrasound, it's widely available and it's relatively inexpensive. It doesn't require an intravenous, and it doesn't use ionizing radiation. It uses minimal pressure, so it's not uncomfortable. For all these reasons, it has great acceptance by patients. And even though MRI is better, recall that in 2 unrelated studies, 40% of the women declined MRI even when it was free. Now, as a bonus, it's easy to guide a biopsy with ultrasound when we can see the abnormality on ultrasound, and it meets 2 important criteria. It finds mostly small invasive cancers, and they're mostly node negative, and it reduces the interval cancer rate. Another test I'll talk about is called tomosynthesis, which is sometimes called 3D mammography or digital breast tomosynthesis. It's not a separate test, it's just a better mammogram. Before it was released onto the market, testing showed that it found more cancers than regular 2D mammograms, and it reduced recalls. It's widely used in the US, but it's not used in Canada for screening except in Alberta and at some sites that are participating in research in BC, Ontario, and Quebec. When it was first introduced, we hoped that the 3D mammograms would find all the cancers we were missing and that we wouldn't need to do supplemental screening, but unfortunately it doesn't. Researchers in Italy compared how many additional cancers were found using 3D mammography compared with ultrasound, and ultrasound found nearly 5 times as many additional cancers as the 3D mammogram. So 3D mammography is still a great idea for screening because it reduces the recall rate, but it does not reduce the need for supplemental screening in women with dense breast tissue. Research from 2 separate hospitals in the Harvard system showed that when used for surveillance, the false alarm rate was lower with 3D, but there was no significant difference in the cancer detection rate between 2D and 3D when it was used for surveillance in survivors. Many of the interval cancers were still being diagnosed when the woman found a lump, and some were found on MRI. Other research shows that 3D does not reduce interval cancer rates, but TOMO's still a good test to do. Now, as I said, it has been shown in a randomized trial to reduce interval cancer rates. So I'm obviously very pro ultrasound screening, since most women can't have MRIs. MRI has been used at women at very high risk since 2007. It finds cancers missed on mammograms, and it has the highest cancer detection rate, 10 to 16 per thousand in the first round. It doesn't use ionizing radiation, but it does require intravenous. And although the intravenous has been shown, the material has been shown to accumulate in various body organs, so far there are no long-term effects. Now with MRI, it's an uncomfortable test. You have to lie on your tummy and lie very still with your breasts hanging down into these slots. And you have to stay still for about 45 minutes in the magnet. You lie on the table, and then they roll the table into the hole there. And claustrophobia is an issue that some women just can't tolerate it if they're claustrophobic. In general, MRI also cannot be done in patients who have pacemakers and other metal implants. It's very expensive, and access is inadequate in many areas. This trial in the Netherlands, they're offering MRI to women with category D breasts after negative 2D mammogram in a randomized trial. In the first year, MRI found 16.5 cancers per 1,000 women. Now, these are not high-risk women other than the fact that they had category D breasts. Most of the cancers they found were invasive. The majority were node negative, and their false alarm rate was acceptable at 8%. Sorry, I did not do that. That doesn't work. There we go. For comparison, as I told you, mammograms find about 5 cancers per 1,000. And women in the trial who had MRI had 6 times fewer interval cancers than women who only had mammograms. And remember, minimizing interval cancers is one of the key goals of screening. But 40% of the women in this group didn't want the MRI, even though they could have it for free. There is now a faster way of doing breast MRI, but it's not in wide use yet. Instead of the conventional scan taking 45 minutes, this one requires only 10 minutes in the scanner, and it's faster to read. This should make it less expensive, and it might make it more tolerable for women with claustrophobia, but it still requires an intravenous. There haven't been large enough numbers of survivors included in studies of this abbreviated MRI yet, but it is better than mammography. It's better than tomosynthesis, better than ultrasound. And so far, the sensitivity is pretty close to the full protocol MRI. So who should have screening MRI? Well, the list is likely to change with additional research, but as of now in the United States, the recommendations are that women with a lifetime risk of greater than 20%, which includes women with the genetic mutations or who've had chest radiation, or women who've had atypia on a biopsy, should have MRI. In Europe, there are new recommendations for MRI for every 2 to 4 years for all women with category D dense breasts, but they acknowledge that there aren't enough MRI machines or staff trained to use them yet. So until there are, they recommend that women who can't get an MRI should have a mammogram and an ultrasound. For breast cancer survivors, it's a bit more complex. Some cancer survivors are at greater than 20% lifetime risk, but not all. It depends on the stage the cancer was diagnosed and whether it was hormone positive or negative and how it was treated. And this refers only to lowering her risk of dying from her first cancer, not to early detection of a second potential cancer in the opposite breast. This graph shows the risk profile of a woman diagnosed at 45. If she has a lumpectomy, the blue lines, her lifetime risk is above 20% until age 66, but her risk is less than 20% if she has a mastectomy. So what about surveillance MRI for survivors? In the US, MRI surveillance is recommended for survivors who have dense breasts and for all women who've had breast cancer diagnosed before age 50, regardless of their breast density. And since studies are showing few or no interval cancers within 2 years of a surveillance MRI, it's been proposed that it could probably be done at 2-year intervals rather than annually. This chart shows the cancer yield for mammograms, ultrasounds, and MRIs and various combinations. And MRI shows the highest when it's done with mammography, that's 16. And the message to take home from this is if you're having an MRI and a mammogram, there's no point also doing ultrasound. Another test that's getting lots of attention is called contrast enhanced mammography. It uses mammography equipment and requires an intravenous, but the contrast is the same one we use for CT scans. And what's really exciting is that it has a similar cancer detection rate to MRI. It's not yet in wide use, but departments across Canada are starting to purchase the necessary equipment. It's also a reasonable alternative to MRI for women who would otherwise qualify for it but can't get it. And this is fast. Once the IV is started and the contrast is injected, it takes about 7 minutes to take all the pictures. There are a couple of blood tests available, sometimes called liquid biopsies. One is from a company based in Calgary, and it's currently available in an increasing number of cities. It's private pay, even though they haven't even finished testing it. It costs about $500, and spoiler alert, it's not ready for prime time, in my opinion. They presented their preliminary data on only 1,100 patients, and they say that it's 92% sensitive in women under 50 with a few false positives, but it's only 79% sensitive overall, meaning that there are lots of false negatives. And their false negatives may be even higher. But stay tuned, because if this pans out, it may be game-changing. Now for the most low-tech way of finding cancers missed on mammograms and dense breasts, breast self-examination. Now the task force says women shouldn't do it, but most women in PEI and elsewhere in Canada who have dense breasts are not having ultrasound. Their cancers are often found as interval cancers. They have a mammogram, it's negative, and at some time after, they bump into a lump. Now, for women with dense breasts who can't have ultrasounds, doing breast self-exam can be the difference between being diagnosed at stage 1 or later. Ideally, all women should do breast self-exam because the majority of women in Canada who will get breast cancer aren't even having annual mammograms. They're only having them every 2 years. Even for women whose cancers will be visible eventually on a mammogram, why let it grow for 2 years till your next mammogram when you might be able to find it on breast self-exam when it's smaller? You shouldn't obsess about it. You don't have to do it every single month, but women need to pay a little more attention. Now, there are lots of demonstrations on how to do breast self-exam on the internet, but an excellent one that I recommend is by Dr. Liz O'Riordan. She's a breast cancer surgeon in the UK who's had breast cancer. Here's her 3-minute how to do breast self-exam. And she also has one online for women who've had mastectomy, teaching how to examine the chest wall. You're going to get these links when you get the recorded lecture. So optimal screening ideally means annual mammograms for all average risk women starting at age 40. Women who are higher than average risk may need to start younger. Women should ideally continue as long as they're in good health with a life expectancy of at least 10 years, and all women should be told their breast density. And women with dense breasts should have access to supplemental screening, usually with ultrasound, MRI, or soon contrast mammography if it's available. Women who've had breast cancer should all have annual mammograms, starting at whatever age they were diagnosed. If you're diagnosed younger than age 50 or you have dense breasts, ideally you should also have MRI or ultrasound. In addition to the good work PEI is already doing, they could improve. They could begin risk assessments for younger women between the ages of 25 to 30. They could offer supplemental screening to all women in category C and D. They could allow all women in good health to continue to self-refer past age 74. And they could implement culturally relevant awareness campaigns for minority women. As an individual, what can you do? Prioritize your health. Find out your breast density. Let us know if you know of opportunities for me or my colleagues to speak to women's groups or your elected representatives. Educate your family, friends, and coworkers. Share this webinar with them. Learn more, including how to speak to your doctor about screening on a website called mybreastscreening.ca. And if you've had cancer, please consider sharing your story on densebreastcanada.ca. Now, Dense Breast Canada is advocating for better screening across Canada, and there's an easy way for you to help. All you need to do is go to this form online. I'll show you how to find it. You just need to fill out your name, your email address, and your postal code, and the website will automatically send a letter to your MP and the Federal Minister of Health. There's a direct link up on this slide, which you'll get later, or you can go to the Dense Breast Canada website and click on this link that says Add Your Voice. Or you can get the advocacy toolkit on the website. Go to the main page on Dense Breast Canada and click on Advocate, shown here with the black arrow. So thank you for your attention. I'm looking forward to your questions. I'm going to stop sharing and